The following podcast is part of a certified educational activity titled Changing the Scenery in ER-positive, HER2-negative metastatic breast cancer with New Oral SERDs and Combinations, Foundations, Evidence, and Practicalities. Access the entire activity and complete the post-test at peerview.com/XYR860. Downloadable slides and practice aids are also available.
Welcome, everyone, to this session, which is Fundamentals and Strategic Insights on Oral SERDs in ER-positive, HER2-negative metastatic breast cancer, How to Overcome Endocrine Resistance. Now, this is part one of a three-part series of virtual workshops that is titled Changing the Scenery in ER-positive, HER2-negative metastatic breast cancer with New Oral SERDs and Combinations, Foundations, Evidence, and Practicalities. I'm Kova Javeri, and I'm a breast medical oncologist at Memorial Sloan Kettering Cancer Center. Joining today is a dear friend and colleague, Professor Stephen Johnston, who's a professor of breast cancer medicine and head of medical oncology, consultant medical oncologist, and head of the breast unit at the Royal Marsden NHS. Welcome, Stephen. Now, our partner here is METAvivor, which is a patient advocacy partner, and it's really an organization that is focused exclusively on stage 4 metastatic breast cancer, with a mission to improve the lives of people living with advanced breast cancer by funding research, advancing policies through advocacy, and facilitating a community of peer-to-peer support. So we're very grateful to METAvivor for contributing insights from a patient perspective and from their care as partners as part of this program. Please also access and use the supplemental resources that is available as a component of this program from METAvivor. We have two important goals for today's discussion. The first one being enhancing our knowledge of limitations of standard endocrine therapy and the impact of endocrine resistance in ER-positive breast cancer. Our second goal is to improve our understanding of the potential of novel ER-targeting agents such as oral SERDs and combinations to address the unmet needs for ER-positive, HER2-negative metastatic breast cancer. So let's kick off by discussing what are the limitations of standard endocrine therapy and the mechanisms of endocrine resistance in ER-positive breast cancer. Stephen, maybe I'll have you talk about this a little bit. And maybe to discuss that, why don't we talk about what do we see after first-line therapy on a CDK4/6 inhibitor? What has your experience been in terms of the prognosis or the survival that you see after patients have already had treatment with a first-line regimen, which contains predominantly an aromatase inhibitor and a CDK4/6 inhibitor?
Yes, thank you, Kamal. I mean, we've had really tremendous progress over the last decade in endocrine treatment for ER-positive metastatic breast cancer since CDK4/6 inhibitors came in. So they transformed the landscape around about 8 to 10 years ago based on trials that established them as the new standard of care and made endocrine therapy alone work much better by overcoming some of the resistance mechanisms to endocrine therapy. But what we find is eventually the cancers become resistant to these treatments, and trying to understand whether it's the resistance to the hormone-based partner, the CDK inhibitor, or the combination guides us as to really what our thinking in as further therapies that might be effective. And we've known for some time that endocrine treatments work well by targeting the hormone receptors. Some of the drugs have limitations in tolerability for patients. We know that in the adjuvant setting. But in the metastatic patient setting, patients by and large take their treatments, well, either alone or in combination with CDK inhibitors. And we get very good responses to initial treatment. But eventually the cancers become resistant. And what we've known for a long time with just endocrine therapy is that by and large, the hormone receptor is resilient. It stays as part of the fundamental biology of the cancer when resistance develops. But understanding why it's resistant to one form of therapy, yet sensitive to other therapies, is what all our research has been trying to find out. And when we've done lots of studies, we've looked to measure various pathways that change in the cancer, and knowing that the estrogen receptor is positively still there, occurs in at least up to 3/4 of the tumors at the point of resistance. There's a small group where estrogen receptors are lost completely and the tumor becomes a completely hormone negative cancer, but the vast majority still have the hormone receptor. And we understand that this could be selection, clonal selection of groups of cells that exist in the primary heterogeneous tumor, or it could be an adaptation of the cancer with the biology changing under the pressure of a hormone treatment, such as an aromatase inhibitor, and a cell cycle blocker, such as a CDK4/6 inhibitor. And knowing the biology has been really fundamental to the development of some of the novel, exciting treatments that are on the horizon now, because the hormone resistance due to an activated mutant receptor is one of the dominant pathways where the cancer still is driven by estrogen receptor, but that receptors become mutant and different. And we'll go into that in a little bit more detail. The other key pathway is that something else goes wrong in the signaling. Cancer cells are complex and they have lots of different pathways that signal down ultimately to the cell cycle, where the estrogen receptor and the cell cycle machinery operate. And when resistance develops, it's often something upstream that's been turned on as a resistance mechanism to overdrive the blockade at a lower level. Various transcription factors, various activating kinases. And studies have really started to understand that in a lot more detail. And with that knowledge, we can actually then start to design targeted treatments that can be very specific to that resistance mechanism. One of the key studies that looked at that is shown here. And this was a very important study from your institution, Kamal, from the Sloan Kettering, where somebody collected biopsies of primary tumors and then metastases and did a great comparative study. They weren't always sequential biopsies. There were a few in patients where they had the primary and then the metastatic, but it was an atlas, a map of the biological pathways. And we learned two really important things in this paper that came out sort of 8, 9 years ago now. One is that the estrogen receptor, the ESR mutations, are a very common problem. And they occur with hotspots in ESR1s, as you can see in that heat map. And if you look in the graph on the left-hand side, you can see in the untreated tumor, these mutations hardly exist. But in the treated tumor resistant to hormone therapy, all of a sudden, a very significant increase in these mutations. The other pathways, the so-called signaling pathways, the MAPK pathways of lots of different various growth factors and kinases that can be activated, appear to occur as a separate group of pathway abnormalities that initially we thought were mutually exclusive. You either had the ESR1 or you had one of these other signaling pathways. And if you understood what those signaling pathways were, you could perhaps design a drug to block them. But this was one of the very first studies that really led us to understand that ESR1 mutations, A, are acquired, and B, are often the only common thing that's going on in that particular cancer. And so if it's clonal selection, then yes, whatever drive we've got on the cancer in terms of blocking it just forces other tumor cells to come to the fore. So if we're blocking production of estrogen, the receptor might still be there, and the mutation receptor that can survive in the absence of estrogen comes to the fore. If we're blocking the cell cycle, maybe some other signaling pathway bypasses that. And then these different mutational clones come to the fore. So I think that's really interesting biology that we learned from that study. And it's been confirmed, as you know, Kamal, in lots of other translational research studies related to ESR1 and the other signaling pathways since then.
Why don't you tell us a little bit more about ESR1 mutations in general?
Sure. So basically, the mutations occur in a critical part of the receptor called the ligand banding domain, AF2. And there are two, the gene is shown here in longitudinal form. There's the DNA binding domain, where it sits down on the estrogen response element upstream of genes that the estrogen receptor is a transcription factor that's regulating certain genes. And the AF1 and the AF2 are the two binding sites for the cofactors, that form that transcription complex. But the ligand binding domain, where the estrogen receptor links with the ligand estrogen, and the AF2 activating domain are where all the mutations occur. You can see here the hotspot, particularly around codon 537, which is a real hotspot of mutations, also 538. So it's very specific mutations, and that changes the conformational shape of the receptor. Just that single mutation in those critical points changes it to a receptor that is what we call constitutively active. It's forming heterodimers and binding to the DNA and transcribing the genes without the ligand being present, which is why it then can turn on in situations of very low estrogen levels related to long-term estrogen deprivation. Now, what you can see in the histogram is that in primary tumors, these mutations are hardly seen, as was shown in the impact study from MSK. But in early metastatic disease, but more importantly, in later disease, the receptor becomes much more common. And what you can see here is a diagram of this mutant receptor with the particular mutation turned on, binding down on the DNA without the estrogen receptor needed to form that interaction. And that's driving what we call ligand-independent transcription and growth of the tumor. So you can have your hormone drug, aromatase inhibitor, sitting there, but it doesn't make any difference. The tumor is just starting to grow. And the various longitudinal diagrams and pie charts shows you that really your chance of picking it up at the first development of metastatic disease is less than 5%. But as soon as you get to progression on the aromatase inhibitor, that is the selection pressure that brings through these mutant clones, and then you can detect them usually 30 to 40% of the time. So that then is a more likely yield of being able to identify them at the point of progression on your endocrine therapy.
So thank you for that explanation about how ESR1 mutations are so much more prevalent in the metastatic setting compared to primary or in the first-line metastatic setting. So really under the selective pressure of therapies, we see this evolution and emergence of ESR1 mutations. Now let's move on then to talk about biomarkers. And really, what is really important in ER-positive, HER2-negative metastatic breast cancer is that we have more than one biomarker that we can test. So the question is, who should we test? When should we test it? What should be particularly tested? And how do we test these? Is there a recipe to testing in the tissue for a particular biomarker or in the plasma for a particular biomarker? It doesn't matter. Would love to hear your thoughts on that, Stephen.
Yeah, I think it's a really important practical question that everybody asks to really guide them in practice as to when, how, and who to test. The key thing is really when it's going to make a difference to your selection of treatment. So that really is at the point of resistance to endocrine therapy, where you want to understand that mechanism. And we have the tools now to do it. Liquid biopsy has really come to the fore as a very reliable, predictable test to do, which is easy. You can see in the cartoon there that if you have a number of different mutations around the body, they might have different mutations. So different clones can set up in a lung metastasis versus a bone metastasis. But in the blood, you have the sum of what's going on in all of those mutations if they're shedding DNA into the blood, and we can do next generation sequencing. And what's been clearly shown when you compare tissue biopsies, which might only get one of those metastases, versus liquid biopsies, your yield of ESR1 mutations is much higher in liquid biopsies rather than tissue biopsies. Equally, the practicalities. Bone is difficult to biopsy. It's painful. You have to decalcify it. You don't always get a positive result. Whereas a liquid biopsy, if there is active disease at the time of progression, is a quick, easy, and reliable test. The second thing is that a liquid biopsy allows you to look for other things, as you've alluded to, because as that MSK study showed, yes, it's ESR1 or it's some form of signal transduction pathway, and the dominant one now is PIK3CA, which is the activating mutations in PI3 kinase, as well as AKT, which is just downstream of PIK3CA, or PTEN, which is a tumor suppressor gene. So if you have any of those three alterations, we now have approved drugs that you can use. And those are just as common, 30, 40% of the time, And they're often inherently there in the primary tumor. They're more truncal mutations than acquired. So an NGS test on a liquid biopsy yields really all the information to help make those decisions. And you can see here that when we've compared digital droplet PCR versus tissue sampling, certainly for ESR1, there's quite a lot of discordance because the ESR1 is more commonly picked up in the liquid biopsy than in the tissue biopsy. Whereas PIK3CA, yes, concordance is quite common between the tissue and the liquid biopsy, but there are again examples where you'll find it in the liquid more often than in the tissue. But because of the ease of testing by liquid biopsy, plus the fact that you've got a higher yield for a number of sites, liquid biopsy has really become the approved, and it's in all the ASCO guidelines that should be the test that you do, particularly at the point of resistance. There's a little bit more nuance now if you develop metastatic disease right up front as to whether you develop a PIK3CA mutation, as you know, Kamal. And I don't know in US practice whether that has changed, because there is evidence from trials with triplet combinations that if you find that PIK3CA up front, that's really important. But in the UK, we haven't really integrated that into frontline testing. That's to me the only example where you might go right up front to test in those early resistant, relapsing early on adjuvant therapy. What do you do?
Yeah, that's such an excellent example of when to test, and do we test it in the first line or second. So I completely agree with you. I think our practices have really adopted and evolved to utilize liquid testing just for all the reasons that you beautifully described, in terms of identifying these mutations and, being able to get all the information across all the sites, because you're just able to collect all that information, shedding from all the different sites in a given patient, rather than relying on one particular site for which you have to schedule the biopsy and get only that information. And ESR1 being an important reason for subclonal mutations. And so certainly liquid biopsies are important and key for identifying them. The prevalence being 40 to 50% there and only 20% in the tissue for those reasons. Now, PI3K, as you said, is a clonal and a truncal mutation, and certainly you can detect them in the plasma. And so very appropriate to do that in plasma as well. However, sometimes if you don't have these mutations in the plasma, or you could be in a scenario where the tumor burden is not significant enough for it to shed in the plasma, I think that's when the gold standard for PI3K would still be a tissue biopsy, and one can reflex to do tissue biopsy. The other scenario that you were alluding to is based on the INAVO 120 trial, which led to the approval of inavolisib, a PI3K inhibitor, in combination with fulvestrant and palbociclib in the first-line metastatic setting. And so certainly our practices at Memorial were always to do the NGS in the first line, because we already have the metastatic biopsy tissue, right, for diagnosis reasons. And so we used to always land up sending them for MSK Impact, our in-house assay. The data that you were referring to was from that assay. And while that was cooking, we started the patients on first-line therapy. But given this approval, I now not only do the tissue testing, which I always did, but I do land up sending liquid biopsy at the same time upfront for patients with endocrine resistance. So those who have recurred on or within 12 months of endocrine therapy. So only for the patients that fit the INAVO 120 criteria, I do send this liquid biopsy in the first line before I start them on therapy, so that the 40% of patients who do have these mutations and are following that endocrine resistance definition for the trial, I can offer them the triplet regimen upfront. But otherwise, for most patients, I will rely on liquid biopsies after their first-line therapy upon progression. So talking about second-line and first-line therapies and these biomarkers, what about biomarker agnostic scenarios? So where we don't see an ESR1, we don't see the PI3K inhibitor, what combinations do you rely on in that setting? And maybe it comes on EMBER-3 as well, which gave us some data there.
Yeah, that's a really important practical point, because if you don't find a PIK3CA mutation or you don't find an ESR1, remember there's a good percentage of patients that might have neither, Then do you just give endocrine monotherapy with fulvestrant or exemestane, or do you give another combination? Endocrine monotherapy in that setting, regardless of whether you've got mutations, has got a very poor chance of working. Median progression-free survival is only, between 2 and 3 months in all of the studies. So it leaves you really with another sort of combination that's a catch-all, either everolimus with endocrine, which is an mTOR inhibitor, in combination, which is further downstream than PIK3CA, either in combination with exemestane or with fulvestrant. There's data for both. And that's an approved combination in the sort of tumor with no biomarkers. Or more recently, data about changing the CDK inhibitor and or changing to a SERD. So we had studies with post-MONARCH, which changed the CDK inhibitor from, say, palbo or ribo with an AI to abemaciclib and fulvestrant, and that was certainly a bit better than fulvestrant alone. But then we had more intriguing data looking at the combination of immunolestrant, which is one of these oral SERDs, with abemaciclib in that situation, and really showing that this was a very powerful combination and that this could be a combination agnostic of what mutations you had. You're covering potentially a better targeted drug against the estrogen receptor. You're using a CDK inhibitor that works in a different way to ribo or palbo, which is often the more common frontline CDK inhibitors. And that showed in EMBER-3 much better activity than using immunolestrant alone. So the SERD perhaps needs another partner with it to make it more effective. And if you don't have any mutations, or potentially you can't get access to the testing, that potentially is a powerful combination, agnostic of the biomarker information. But even if you have negative biomarkers, it could become a new standard of care in that situation, not compared against everolimus with or without fulvestrant or exemestane, but you look at the median PFS in that study, particularly in patients who'd responded well to their CDK inhibitor. So if you look at those with an ESR1 mutation and prior benefit from CDK inhibitors, suddenly you're looking at median PFSs in excess of 12 months for that combination. And that far outstrips anything else we'd seen in the second-line setting. So I think EMBER-3 in that respect is a really very intriguing data.
Yeah, no, I think such an excellent point that we now at least hopefully in the future will have choices which crosses that 6 to 7 month. I feel like the second line PFS was kind of stuck for that 6-month PFS for a long period of time. So it was really nice to see some data where you can see a further durable response to therapy. And so I think hopefully we'll have this available in the near future and can utilize that in that setting. So last, I would love to touch upon the next generation therapies and how they are at the inflection point and the foundational considerations and strategic insights into targeting the estrogen receptor with oral SERDs, novel endocrine agents, and the various combinations. So what are some of the new classes, Stephen, of ER targeting therapies that are showing promise, and how do they really work, if you can walk us through that?
Yeah, I mean, this is a one-stop slide that I show because it kind of is a nice cartoon. I'm quite pictorial in my thinking, so I like to think of a receptor and something zapping and targeting it. But it also lists how busy the area is, not only in terms of the SERDs in development, elacestrant in green and fulvestrant are the two approved SERDs. We have other ones coming through, but also the other classes of drug that are targeting the estrogen receptor. So SERCers, which are covalent linker inactivators. We have serins, and we have PROTACs, which are the new version of drugs that target the ligase that is involved in the degradation of the estrogen receptor and produce apparently much greater destruction of the estrogen receptor compared to other SERDs. So ultimately, you can see in these different diagrams how they all vary compared to either the classical estrogen or tamoxifen model, by basically trying to destroy and degrade the receptor and inhibit gene transcription. Now, we've got limited data for some of these drugs. We saw some data at ASCO with vepdegestrant, which is the PROTAC, which was a head-to-head comparison of fulvestrant, again showing better than fulvestrant in ESR1 mutated cancer, but probably not dramatically different to a lot of the other drugs. We've done some experimental work with H3B, the SERCA drug, which certainly has activity. Some of them have slightly different adverse events. You get some bradycardia coming up, you get some eye toxicities, you get some GI toxicities with some of the oral SERDs. So they're all a little bit different. But the key thing is that they're all variations on a theme of how to target the receptor, whether it be the mutant receptor or the wild type receptor. And which one will turn out to be the winner, I think, is the result of ongoing trials, and also which one is ultimately the best tolerated drug. Because ultimately, in some of the trials we're doing at the moment, these could replace aromatase inhibitors in a frontline setting in combination with a CDK inhibitor. And if they ended up being more effective and better tolerated, they're a home run for potentially going into the adjuvant space as well, because long-term tolerability in an early breast cancer setting is really all about being able to stay on the drug. So there's a lot of interest and a lot of promise that some of these might work their way all the way through into the early breast cancer setting.
Yeah, no, really, really exciting times. As you said, we have approved agents. We have data from the VERITAC-2 with peptigestrant and from EMBER-3 for imlunestrant. And certainly we have lasofoxifene, a novel SERM. In the ELAINE trials in late phase development, we have the CVAN, palazestrant, also in late phase trials. So really a lot of exciting data. We now have data for camizestrant as well, which really brings us to a very important question. I think the way I think about these novel endocrine agents and what kind of strategies we've tried to adopt to address this in clinic, I think about them as three broad categories. One for which we already have an approved drug, which is in the second line post CDK4/6 inhibitor. And that's where we have monotherapy approval for elacestrant in ESR1 mutant tumors. Certainly, VERITAC-2 gave us the same data with peptigestrant. We have data from EMBER-3 for imlunestrant alone in ESR1 mutant tumors. You talked us through imlunestrant plus abemaciclib from EMBER-3 as well as a way to further move the needle in the right direction. So that's our post-CDK strategy. Then at ASCO, we also saw data, which was also simultaneously published from SERENA-6, which was a very novel way of trying to target emerging ESR1 mutations on first-line regimen without radiological progression. So can we intervene early in first line just with emergence at the molecular level without radiological progression? And would that be a strategy we should adopt in clinic, homogeneously for our patients? And last, we're awaiting data for the upfront strategies where we're trying to see if these novel endocrine agents can replace aromatase inhibitor as a backbone with CDK in the first line. So what are your thoughts about these three different kind of strategies, and what do you think would be an appropriate one? Is there one successful one in your mind? How do you think about them?
Yeah, I think it's appropriate that we test all the scenarios. I've always had concerns about the upfront ones for two reasons. One, it's going to be hard to beat an AI plus a CDK inhibitor. That was a quantum leap we made 8-9 years ago when those trials changed practice. And it would require another quantum leap to really push back from, the sort of, 28, 30 months to much longer. And the other thing I'm concerned about is exactly what we talked about earlier, that the longer you suppress one bit of the mechanism, cancers are often smarter than the oncologists who dream up the drugs, and they just learn different ways to come around. So there's a risk that the median PFS may not be that much different because other mechanisms develop. Because ESL1 from a very low level to a higher level, with the upfront, you're just trying to catch that early and prevent it. But will you allow other things to develop? So I have concerns, but we'll see data hopefully soon from Persevera, SERENA-6, which are the sort of furthest along of those trials. SERENA-6 was fascinating because it was proof of principle of a lovely French study, part of one, where if you measure regularly for the ESR1 specifically, so you're just looking for that one mutation, you find it, you intervene early, you can clear the DNA, and you can control the cancer for longer than if you don't make the switch. But there's a lot of concern about whether or not that trial really changed the progression to the second and third line treatment, because there wasn't crossover in the trial, that everybody on the AI arm then got their CDK, their SERD at the point of resistance clinically compared to molecular progression. So it's also going to be, can we afford to test everybody every 3 months to pick up 10, 20% of people who get the mutation testing? But as a proof of principle that finding the mutation, targeting it works, brilliant study. So I think at the moment in my practice, they wait until you found the mutation, then you give the targeted drug. I wait with interest the upfront studies to see if there's a real quantum movement there. But at the moment, I put my money on really waiting to see if you can pick it up and find the mutation at resistance. Where Serena 6 might be important is a sort of an indication of what would happen in the adjuvant setting. Because in the adjuvant setting, the switch strategies could end up being better than the upfront strategies because you're detecting microscopic disease before it develops. You're not looking for the mutations, you're just making the general switch at the point the resistance might be developing. So I think Serena 6 could be an indicator that the delayed switch adjuvant studies will be positive, but I'll place a bet on that, and we can see if the wager comes in 4 or 5 years' time.
I am currently putting the wager and the bet with you on that. So right spot on. And this is exactly how I think about it as well. And this is what I do in practice in the metastatic setting currently today as well. So thank you for summarizing that so beautifully. And last, I'd like to move on and talk about patient perspective and experiences. And with that, would love for you to see this video from one of our patients who's sharing their experiences with older endocrine therapies and hope for better outcomes with this newer targeted agents such as oral SERDs. And really, we want to discuss the importance and the relevance and implications of biomarker testing with patients. So watch this video.
Hi, I'm Kelly Shanahan. I've been living with metastatic breast cancer for almost 12 years. I am the president and director of research of METAvivor, a nonprofit that raises money and funds metastatic-focused research. I'm thrilled to be with you today to give the patient perspective. Endocrine therapy for estrogen receptor-positive metastatic and advanced breast cancer is not easy. The drugs that we have to take cause a lot of side effects, which is probably why so many people in the early stage setting stop taking their medications before the 5 to 7 year mark that's recommended. In the metastatic setting, we still have these side effects, but we might be on these medications indefinitely. Things like joint pain, vaginal dryness, cognitive issues, they're hard to take. And some of the medications require a shot. In the cheeks you don't smile with, both of them, every month. Patients want and need other alternative methods for receiving endocrine therapy. We are getting more and more biomarkers available, things that can help determine what treatments might be best for us as individuals. And I think it's really important for us as patients to be proactive and ask our doctors about biomarker testing, about testing for things like the ESR1 mutation, which 40% of us will develop after being on traditional endocrine therapy like aromatase inhibitors. Especially if your doctor is not a specialist in metastatic breast cancer, if you are seeing a general oncologist who treats everything, the field is exploding right now, and it's really hard to keep up. So we as patients need to be empowered, need to be educated, and need to be comfortable talking with our care team.
And with that, I'd really like to thank Dr. Johnston for his insights, for his thoughtful comments, for his thoughtful explanations about the role of ESR1 mutations and all these novel endocrine therapies and the various strategies that are currently in place, some approved, some in the making, and some very close to being available in terms of data that might further impact our practice. We really can't wait to see those data and how they can further impact patient outcomes, and more importantly, see how they might be utilized for early stage breast cancer to further improve survival for our patients with ER-positive breast cancer. So thank you all for joining today. Dr. Johnston, any other comments you might want to have?
No, thank you very much. I think that was a very interesting discussion. It's a very active time in research at the moment, but also a very promising time for patients as these therapies come through as approved treatments.
Absolutely. Thank you all. Welcome to the session of novel oral SERDs and combinations in ER-positive, HER2-negative metastatic breast cancer, interpreting the evidence and implications for real-world practice. Now, this is part 2 of a 3-part series of virtual workshops titled Changing the Scenery in ER-positive, HER2-negative metastatic breast cancer with New Oral SERDs and Combinations, Foundations, Evidence, and Practicalities. So I am Koma Jiveri. I am a breast medical oncologist at Memorial Sloan Kettering Cancer Center, and I'll serve as the series chair and the show host for today. And joining me is a friend and colleague An expert speaker, Professor Giuseppe Corigliano, who's a full professor of medical oncology at the Department of Oncology and Hemato-Oncology in University of Milano, and director of the Early Drug Development for Innovative Therapies. Welcome, Giuseppe, to this session.
Thanks for the invitation.
We have two important goals for today's discussion. First, we want to equip ourselves with knowledge about the efficacy and safety of oral SERDs and other novel ER-targeting therapies and rational combinations in ER-positive, HER2-negative metastatic breast cancer. And second, we want to enhance our understanding of the clinical and practical implications of the recent studies assessing new and emerging ER-targeted therapies in ER-positive metastatic breast cancer. Starting with innovations in ER-targeting therapy for ER-positive, HER2-negative metastatic breast cancer, talking about oral SERDs, combinations, and beyond. And Dr. Corigliano will now walk us through some of the early trials with these agents and what have they shown us thus far. So, Dr. Corigliano, up to you.
Thank you, Humala, for your kind introduction. Yes, you are right. We have new oral SERD under development. And if we have just to summarize all the data available, we can start from a MIRA-3 and Accelera trial. The first one with amsenestrant that failed to demonstrate a median progression-free survival benefit at data readout, despite there was a trend for positivity in ESR1 mutant. Similar data for giredestrant in the Accelerate trial, negative readout for median progression-free survival, but trend for positivity in ESR1 mutant. The only oral SERD today approved is elacestrant, based on the data of the Emerald trial. Elacestrant demonstrated a clinically significant and statistically significant improvement in median progression-free survival in both overall population and specifically in ESR1 mutant, and actually is approved only for ESR1 mutant ER-positive metastatic breast cancer. The SERENA-2 is another trial in which two different doses of camizestrant have been tested, and there was a clear benefit in terms of median progression-free survival. Just to summarize the data, as you can see here, in the Accelera trial, there was a trend for positivity in ESR1 mutant, similar data in the AMIRA trial, even if not statistically significant. Clear benefit in the Emerald trial, where elacestrant, when compared to standard of care endocrine therapy, improved median progression-free survival in ESR1 mutant metastatic breast cancer.
Based on these trials, I think what has become very clear is that certainly with monotherapy post-CDK4/6, we are seeing benefit, particularly in ESR1 mutant tumors. It's not that we're not seeing benefit in ESR1 wild type, but we've not been able to show statistical significance. So that's one thing. Positive or negative study, benefit is seen in ESR1 mutants as monotherapy. But a very important realization is also that 40% across the board will still develop early progression on monotherapy, and 60% still have less than 6 months of benefit. So do you think we need rational combination approaches to expand those benefits? And on that end, do we have any data that you can walk us through?
Yes, you are absolutely right. I believe in the ideal world, we should combine an oral SERD with CDK4/6 inhibitors because we have the rationale to combine an oral SERD with other agents. I would like to summarize the data of the EMBER-3. This was a prospective randomized trial in which patients pre- and post-menopausal HR-positive, HER2-negative who received prior adjuvant therapy with a recurrence within 12 months of completion of AI plus CDK4/6 inhibitors or progressed to a first-line AI plus CDK4/6 inhibitors have been randomized to receive imlunestrant alone, standard of care, including fulvestrant or exemestane, and then finally the arm C was imlunestrant plus abemaciclib. The primary endpoint of the study was to compare A versus B, like in the Emerald trial. A versus B in all patients and ESR1 mutant, and finally A versus C. 42% of the patients in the imlunestrant arm were mutant for ESR1. 39% of them had also a PI3 kinase mutation. The most recent endocrine therapy was in 63% of the patients, a treatment for advanced breast cancer. And when evaluating previous CDK4/6 inhibitors, we have Palbo in 61% of the patients, ribociclib in 29%, and abemaciclib in 10%. So usually the characteristics were very well balanced, including in patients with ESR1 mutation. If we look at the data, imlunestrant showed reduced risk of progression or death compared with the standard of care in patients with ESR1 mutation. So imlunestrant led to a 38% reduction in the risk of progression or death in patients with ESR1 mutation. The other primary endpoint was to evaluate median PFS in the intent to treat population. And as here reported, that there is absolutely no difference. Median progression-free survival was 5.6 months in the imlunestrant arm, 5.5 in the standard of care. So the majority subgroup of patients without ESR1 mutation showed no difference in median progression-free survival. The next question was whether we can combine imlunestrant plus abemaciclib, and when comparing arm A, imlunestrant alone, versus arm C, imlunestrant plus abemaciclib, median progression-free survival was improved from 5.5 months to 9.4 months. So the combination of imlunestrant and abemaciclib led to a 43% reduction in the risk of progression or death over imlunestrant alone. What is really interesting, when evaluating in a subgroup analysis the benefit of the combination in ESR1 mutant or in ESR1 wild type, there is exactly the same benefit. This is a very important information because if the combination will be approved, we don't need to test. We can prescribe directly the combination of imlunestrant plus abemaciclib, avoiding the stress also of ESR1 mutation detection. In another subgroup analysis, imlunestrant plus abemaciclib was investigated in the patient population who received prior CDK4/6 inhibitors, so with the PI3 kinase mutation. Also, in these two subgroups, there is a consistent benefit of imlunestrant plus abemaciclib in both the population who received previous CDK4/6 inhibitors and in the population with PI3 kinase mutation. Evaluating, of course, all the subgroups, there is a consistent benefit of the combination of imlunestrant plus abemaciclib, independently of previous CDK4/6 inhibitors, ESR1 mutational status, PI3 kinase mutation, or concurrent mutation of PIK3CA and ESR1. And here, in this beautiful slide, you can see all the subgroup analysis according to ESR1 mutation, overall population, and of course also second-line previous CDK4/6 inhibitors and other parameters. What's about safety? This is really important. Imlunestrant was very well tolerated. Let's say that incidence of grade 3 or more toxicity was reported only in 17% of the patients. Diarrhea grade 3 in less than 1%, mainly related, of course, to the use of imlunestrant alone and other oral SERD. In the combination arm, imlunestrant plus abemaciclib, diarrhea grade 3 or more was reported in 8% of the patients. Of course, the safety was more consistent with the known abemaciclib profile rather than imlunestrant. During ASCO, we presented the data of patient-reported outcome, and we evaluated global health status and quality of life and functional domains.
across the subgroup of the EMBER-3 trial, and consistently with the primary results of EMBER-3, the patient-reported outcome results reinforce the benefit of imlunestrant as a monotherapy or combined with abemaciclib as an all-oral targeted therapy. I would like to mention only the data of time to deterioration analysis, in which usually there was a numerically better outcome for patients who received imlunestrant versus standard of care, much more better in the combination imlunestrant plus abemaciclib. And another important point was the importance of injection site reaction, that for the majority of the patients was a major concern. So having an all-oral combination is a unique opportunity for patients with HR-positive, HER2 negative metastatic breast cancer.
That's such fantastic a way of ending that on that note. And thank you for walking us through this comprehensive data set from the phase 3 EMBER-3 trial. So let me pause here to ask you a couple of questions that I was thinking about with respect to this data set, and what should we be thinking about? Do you think combinations are the way to go? We already have monotherapy. How do you think we should be making our decisions, or how will you be making your decisions? Say if you had a doublet available or a combination therapy available, who would you offer monotherapy and who would you offer a combination to?
Oh, this is an excellent question. So personally, I believe that if the combination will be approved, I will propose to all patients in the second line the combination of imlunestrant plus abemaciclib. We know very well that oral SERD monotherapy can provide a very limited benefit. If you have to observe the long-term benefit is only in the patients with the longer exposure to previous CDK4/6 inhibitors for more than 1 year or more than 18 months. So personally, I believe that having the combination, I would avoid potentially the testing, and I would give imlunestrant plus abema to any patient in the second line setting. We know already that CDK4/6 inhibitors beyond progression can give a benefit to the patient. So having the opportunity in ESR1 mutant or also in the wild type, I would like to be provocative here. To give imlunestrant, I believe this can be a huge opportunity for our patients.
Thank you for sharing that. You know, one of the things I was thinking about, EMBER-3 did allow patients to get enrolled and be treated either in the first line, which represented, as you showed, in 30% of the patient population, and then the most majority of the patient population were treated in the second line. So do you think if this combination was available, would you consider this, and when would you consider this in the first line?
No, personally, I would rely on the data of AI plus CDK4/6 inhibitors for endocrine sensitive and fulvestrant plus CDK4/6 inhibitors for the resistant. So personally, I would not consider this regimen in the first line. I would prefer to give this type of treatment to patients in the second line setting, unless, this is a personal comment, in the first line, in endocrine resistant disease in a patient who underwent, let's say, an NGS, you discover that there is an ESR1 mutation. Maybe in that specific scenario, I would consider personally the combination of imlunestrant plus abemaciclib.
I completely agree with you. Yeah, I think the point you brought up is excellent about the ESR1 mutation there, that in that setting, which is not a majority, I think we've seen about 5 to 7% prevalence at baseline, the full first-line metastatic therapy there, I would definitely be leading and reaching out for imlunestrant abema if that was available. And maybe to your point, I'm just, stretching ahead, for an endocrine resistant where I was considering fulvestrant, given the data that you showed, whether you see an ESR1 mutation or not, and you're seeing the benefit, I might be okay using this all oral regimen, and I would certainly have a discussion with the patient on that for this endocrine resistant patient population. But for a sensitive patient population, I think I would certainly be only reaching out for AI CDK. The only reason I would be considering fulvestrant CDK, is if the patient preference is there for various reasons, including cost or access. But otherwise, I think that for endocrine resistant, it seems like it could still be a reasonable option to think about the doublet combination in the first line, given that EMBER-3 did not allow progression on prior fulvestrant, and we really don't know what imlunestrant abema would fare after, say, fulvestrant ribo. So I think we don't necessarily have that data set, but I don't think that that's a big proportion of patients in clinic.
This is a very good comment. Personally, I was very surprised when I saw the data on patient-reported outcome, since this educational module is also for patients. So patients complain about intramuscular injection of fulvestrant. And personally, I can tell you that in ESR1 mutant, imlunestrant is superior to fulvestrant.
Right.
But in ESR1 wild type, it's not inferior. So if a patient would prefer to receive a null oral combination, we need to guarantee the access to this type of combination also in the wild type, because as I showed at ASCO, it's very clear that patients complain about intramuscular injection of fulvestrant, and quality of life of patients in this setting is a priority for me.
Fantastic. Yeah, no, I think excellent points. So moving on, I think we heard about monotherapy data from you, Giuseppe, post CDK4/6, and we saw that it's approved in ESR1 mutant tumors. We heard about the data from EMBER-3 for combinations and how that was active regardless of any mutation. What about the ctDNA adaptive approach, where you're tracking the emergence of ESR1 mutations on first-line therapy, on first-line AI-CDK, and then switching to an oral SERD for emergence of these mutations without radiological progression? Maybe you can walk us through what did we learn from such a strategy in SERENA-6?
Yes, this is an excellent question. The first study to demonstrate that intersection of ESR1 mutation and switch to a SERD that in that scenario was fulvestrant can improve the median progression-free survival. And the PADA-1 almost 2 years ago clearly demonstrated what is reported in the SERENA-6. The SERENA-6 is exactly the same design of the PADA-1, prospective randomized trial for patients receiving a first-line treatment with AI plus CDK4/6 inhibitor that have been tested for ESR1 mutation every 2-3 treatment cycles, and once ESR1 mutation was intercepted without radiological progression, patients have been randomized to switch to camizestrant 75 mg versus the same treatment, so AI plus CDK4/6 inhibitors. If we check the patient characteristics of the SERENA-6, this is an important information. Almost the majority of the patients had the median exposure to AI plus CDK4/6 inhibitors for 22 months. And time from initiation of AI plus CDK4/6 inhibitor to randomization was more than 18 months for 62% of the patients, and less than 60 months for 38% of the patients. Just to remind to you, almost 60% of patients tested intercepted the ESR1 mutation on the first determination. With this switching strategy of ESR1 interception without radiological progression, the SERENA-6 demonstrated a median progression-free survival benefit from 9.2 months to 16 months, and the benefit was very clear since the beginning. This is a slide that I would like to comment a little bit. Here is reported one item of the EORTC quality of life Q30, and here is demonstrated that time to deterioration and global health status quality of life was delayed by anticipation of camizestrant. Why I would like to comment on this, because we know perfectly that aromatase inhibitors can give a lot of side effects, arthralgia, fatigue, insomnia. So I would like to know if this delay in time to deterioration is more related by the switch to camizestrant rather than to a real delay in time to deterioration. In terms of adverse events, the majority of adverse events were of course, related to the safety profile of the CDK4/6 inhibitor, so neutropenia, anemia. In terms of photopsia, this was reported in 20% of the patients with only 1% grade 3. So photopsia is there, but finally seems not to be a major issue for our patients.
No, I think this is great, and I think it's a great effort to try and see how can we make a difference even before we see radiological progression, which is what we currently utilize in clinic when we're thinking about switching therapies. And by doing this approach of molecular progression and intervention for molecular progression, can we improve outcomes? So do you think the data from SERENA-6 addresses that question of can molecular progression-related interventions change outcomes to the point that it should become a standard of care?
The trial design, you would agree with me, is beautiful. No, it's the ideal trial design of precision medicine. You know, we are missing the crossover arm here. So I would like to see whether patients with the radiological progression at the end of the story may derive exactly the same benefit if you have a crossover arm. I believe the absence of the crossover will limit a lot, I believe, the implementation of this type of approach. So personally, I believe the data are practice changing. For sure, they would be reported in clinical practice guidelines, but between guidelines and implementation in clinical practice, I believe there will be a gap. So why? Because we don't have the data of the crossover, and this is a consideration that should be done.
Yeah, no, I think it's an excellent point because, as you pointed out, there are options available to patients at the time of progression. So, not having this crossover, but, when otherwise we should have had, patients who can get these oral SERDs at the back end and maybe even combination of oral SERDs with targeted therapy at the back end. Are we truly, based on this data set, able to confirm that we're making a big difference in outcomes? So I think I agree with you. I think it's an excellent study. I think it's an excellent futuristic view of trying to make a difference in patient outcomes that we need to adapt to and learn more about in clinic. We need to design more studies like this. And I think this study is probably setting the stage as a foundation, in addition to PARA-1, to then raising all the important questions that we still need to continue to address before we can definitively say, yes, this is the way we need to do because this makes a difference in patient outcomes. So completely agree with all the comments that you have made. So thank you for that. Maybe other trials that are also ongoing, talking about these combinations, hopefully they will be available and maybe we'll be able to offer additional options to our patients. You want to walk us through some other designs?
Yes, I will summarize very briefly this data. Of course, the ADELA trial that is exploring the combination of elacestrant plus everolimus versus elacestrant plus placebo. As you know, still in Europe, everolimus is used in patients without PI3 kinase mutation. Then we have the Pioneer trial, giredestrant plus CDK4/6 inhibitors versus fulvestrant plus CDK4/6 inhibitor, and the EVERAR trial, combining giredestrant plus everolimus versus standard of care plus everolimus. Another trial is the Persevera, giredestrant palbo and letrozole. This is a trial in the first-line setting, very similar, of course, to the ones that have been already performed. And finally, camizestrant plus palbo plus anastrozole placebo. The SERENA-4 will be available for sure at ESMO this year, so we will see whether an oral SERD plus CDK4/6 inhibitor is better than a standard of care. And then we have a lot of trials in the adjuvant setting, the treat ctDNA using elacestrant by ESR1 interception in the high-risk population in the adjuvant setting. And then we had the Cambria-1 and Cambria-2 that are trials in which there is a frontline use of camizestrant plus CDK4/6 inhibitors in the high-risk population and alone in the other population. And then the Glidera trial, so giredestrant for 5 years plus abemap for 2 years, and EMBER-4. This is a large prospective randomized trial including thousands of patients, and evaluating the role of imlunestrant in the adjuvant setting. So up to you to comment on the adjuvant trials.
Yeah, no, I think it'll be very interesting to see what strategy might be the most impactful, because I think certainly the advantage to these oral SERDs is the tolerability profile. While there are differences in the safety profile, they are all predominantly low-grade toxicities. And can they overcome the toxicity issues that we face with, say, aromatase inhibitors and tamoxifen in clinic? That's one big impact. Hopefully, these trials can shed light on when they're reported out. But I think a strategy of whether it should be an upfront way of, randomizing oral SERDs with these standard of care drugs versus a switch strategy after a couple of years is something that is being evaluated in EMBER-4 and in Cambria 1 study. And I think it'll be interesting to see which strategy might be effective. And certainly the treat ctDNA is, again, focusing on, can we utilize ctDNA-based adaptive strategies to see if we can make a difference in early stage. So really looking forward to seeing what those readouts would look like and what strategy might be the most appropriate. I don't know if, Giuseppe, you had any thoughts if one of the strategies, resonated more with you or your thought process, if you want to comment on that.
But for sure, in the high-risk population, I prefer the switching strategy. If you remember, in the Big 198, the switching strategy was exactly the same that the frontline AI. And in this context, switching from an AI to an oral SERD can improve also the quality of life of patients. And in the adjuvant setting, you know better than me that quality of life is an issue, because side effects of AI, mainly for premenopausal patients, are a nightmare, and we manage a lot of side effects of AI in the premenopausal setting, but also in the postmenopausal.
Excellent point about side effects and tolerability and adherence. We know that the adherence for standard of care AI and tamoxifen, 50% of our patients don't even finish 5 years of therapy. And so this is very, very important to improve mortality rates and to improve outcomes. And very interestingly, when we look at the phase 1 data sets for these oral SERDs, we've learned that none of them really hit the maximum tolerated dose. I think the recommended phase 2 doses were selected based on the safety, PK, and efficacy profile, so a biologically effective dose. And so we have the ability to dose reduce these drugs, which is not something we can do with aromatase inhibitors and tamoxifen, which is fixed dosing. So hopefully all of those attractive features and these strategies that are currently being studied, it will make a big impact in outcomes, in adherence, and in toxicity rates. Now, besides oral SERDs, which have certainly been really, really impactful and have been approved, and many are in phase 3 settings in various different strategies, including early stage now, there are other emerging novel endocrine therapies as well. Maybe, Giuseppe, you can talk to us a little bit of those novel endocrine strategies, their mechanisms of actions, and maybe some data sets that have recently been reported out.
So we have novel SERM like lasofoxifene or bazedoxifene. Lasofoxifene was a drug that tested 10 years ago for the treatment of osteoporosis, and now this is a drug repositioning, and there is a registration trial ongoing. We have SERCA, selective estrogen receptor covalent antagonist. H3B6545 is an example. Then the PROTAC, vepdegestrant, is an example, a proteolysis targeting chimera. And then the SERAN, complete estrogen receptor antagonist like palazestrant. We have data from vepdegestrant. They have been presented at ASCO this year. The VERITAC-2 was a global phase 3 randomized trial for HR-positive, HER2-negative disease, comparing vepdegestrant to standard of care. In this case was fulvestrant, with the primary endpoint that was PFS in intent to treat population and ESR1 mutation, exactly like in the EMBER-3 and the EMERALD trial. The benefit in the primary endpoint was a marginal benefit in ESR1 mutation, absolutely no difference in the overall population. When evaluating investigator-assessed PFS, here again there was a benefit in patients with ESR1 mutation and no benefit in the overall population. Here we have a safety profile that is a little bit different respect to other drugs. We have fatigue in 27% of the patients, increase on AST and ALT in 14%. And finally, discontinuation rate was reported in 3% of the patients. I don't know whether or not there will be further development for vepdegestrant, but it's a very interesting mechanism of action.
Fantastic. And last but not the least, we have patient perspectives and experiences and insights from METAvivor group. So this is really a patient video that I'd like you to watch that highlights the importance of patients' understanding of new therapy options such as oral SERDs and other ER-targeting therapies, patient-reported outcomes, and the benefits of making this information accessible to patients.
There are so many treatment options available to your patients, and it's important that you discuss all the available options with every single one of your patients. Don't make assumptions about what someone may want based on their age or something else. We have the older therapies like aromatase inhibitors or tamoxifen, and we have the newer oral SERDs and more of those coming down the pike every day. We have the injectable SERDs. We have Protex and Serans and every other version of alphabet soup that may become available. So talk to your patients about all the options. Everybody's different. But if you have these discussions with your patients, you can help them come to an informed decision. I think it's also really important to talk to your patients about patient-reported outcomes that may not have been presented in the initial clinical trial data, because we all know that the cancer Olympians that are in the trials are different than the real-world population who will be taking the drugs. So again, give your patients all the data, work with them so that everybody is happy with the choice of endocrine therapy.
So in summary, I think we really heard a lot of rationale for utilizing oral SERDs for ESR1 mutant tumors in the metastatic setting. We saw a lot of exciting data and the wave of the future and the rationale for combinations in this space. So beyond CDK4/6 in the first line, utilizing novel endocrine therapy approaches, not only as monotherapy, but certainly reaching out for combinations. We await additional combination trial data sets, including agents targeting the PI3K/AKT/mTOR pathway, some of which will be reported out later this year, and we'll see how that impacts our treatment paradigm. Certainly a lot of excitement for early stage with oral SERDs to see how can we further improve outcomes in early stage as well. I'd really like to thank you all for joining us today, and thank you, Dr. Corigliano, for such an excellent discussion and providing your insights in this area.
Thank you for the invitation.
Welcome. Today, we'll talk about integrating oral SERDs and combinations into the ER-positive, HER2-negative metastatic breast cancer treatment arsenal, and really review practical guidance for multifactorial clinical decisions. Now, remember, this is a part 3 of a 3-part series of virtual workshops, which is titled Changing the Scenery in ER-positive, HER2-negative metastatic breast cancer with New Oral SERDs and Combinations, Foundations, Evidence, and Practicalities. I'm Komal Javeri, a breast medical oncologist at Memorial Sloan Kettering Cancer Center in New York, and joining today is a dear friend and colleague, Professor Joyce O'Shaughnessy, who is the Celebrating Women Chair in Breast Cancer Research at Baylor University Medical Center in Texas. Welcome, Joyce.
Thanks, Komal. Good to be here with you.
The 2 goals for today's discussion are first, to equip us with skills in developing individualized treatment plans for patients with ER-positive, HER2-negative metastatic breast cancer, incorporating oral SERDs and combinations. And second, to provide us with strategies for engaging patients in shared decisions about treatment selection, as well as improving the adverse event management and adherence when utilizing oral therapies. So let's kick off by putting data to practice in a step-by-step fashion and talk about the practical strategies for integrating oral SERDs and combinations into treatment plans for patients with ER-positive, HER2-negative metastatic breast cancer. Now, here's what has been happening to date. We've had a rapid advancement in terms of having novel endocrine agents being available, either as approved agents or as newer data and has since been reported, which will hopefully soon change our treatment landscape. Essentially, we've had oral SERD monotherapy trials where we've seen a consistent benefit in patients with ESR1 mutations, but we have also recognized that 40% across the board in these trials still develop early progression on monotherapy, and 60% still will have only a less than 6-month benefit, really highlighting the unmet need for combination therapies. Talking about combinations, we had data that was presented and published from the EMBER-3 phase 3 trial, where not only did we see monotherapy, again, activity in ESR1 mutant tumors, but we also saw data for the combination of imlunestrant and abemaciclib, which was better in terms of improving progression-free survival compared to imlunestrant alone. And this was seen regardless of ESR1 mutations and even despite prior CDK4/6 inhibitor progression. More recently, at the ASCO annual meeting, we saw data, which is also published now, from the phase 3 SERENA-6 trial, a very interesting trial, very important trial, where we were trying to focus on really targeting emerging ESR1 mutations. So really make an intervention with molecular progression without radiological progression. And we saw that when we switched the AI CDK to camizestrant and continued the same CDK during first-line therapy, there was an improvement in PFS compared to when we continued the same AI CDK combination with emerging ESR1 mutations. And not only have we seen monotherapy data with oral SERDs, but we've also now seen that with a PROTAC, a proteolysis targeting chimera, in the phase 3 VERITAC-2 trial, where we showed superiority for vepdegestrant compared to fulvestrant in patients with ESR1 mutant who had prior treatment with a CDK4/6 inhibitor therapy. Many other trials are still underway, including combination trials in the first-line endocrine therapy setting, and several other combinations, including with everolimus, that are currently ongoing. So maybe I'll pause here for a second, Joyce, and see what do you think about these data, and where might these new therapies fit within our existing treatment algorithm?
Very exciting times. These are like paradigm changing, some of these trials. You know, the whole SERENA-6 raises the question of, should we try to detect molecular progression in the first line setting prior to the detection of clinical progression? Will that ultimately improve survival or substantially improve quality of life? So fascinating. It is great with EMBER-3 to have a combination of an oral SERD with another targeted therapy, in this particular case, abemaciclib, a CDK4/6 inhibitor. We need combinations. And it's great to see more single-agent oral SERDs, but also the vepdegestrant, that brand new mechanism of action. Very, very exciting. And we'll look at some algorithms and see where these might fit in as we go along.
Yeah, thank you. So before we get into the algorithm, why don't we talk about this case? So we have a 59-year-old postmenopausal woman with ER-positive, HER2-negative metastatic breast cancer. Now, she was really diagnosed with de novo metastatic disease with numerous liver and bone metastases that included spine, hip, and ribs. Very appropriately, she received first-line CDK4/6 inhibitor therapy, in this case ribociclib, with an aromatase inhibitors. But unfortunately, 18 months into this therapy, developed asymptomatic progression in bone and also new liver lesions. ctDNA testing was performed at the time that revealed presence of ESR1 mutations and no alterations in the PIK3CA, AKT, or PTEN. There was no evidence of germline BRCA1 or 2 mutations as well. And maybe, Joyce, why don't you tell us, how do you think about these treatment options, and where do you think they fit in our treatment algorithm?
Absolutely. You know, metastatic breast cancer has become more complex because we do need to do NGS genomic evaluation of the cancer at various steps along the therapeutic continuum because of the emergence of new mutations. And so with this particular patient, she was de novo metastatic. So in the red box, the upper half of the slide, very nice algorithm here, where she receives, as you see, first line treatment. She received the AI plus CDK4/6 inhibitor. She benefited. She had 18 months. Now we need to think about second line treatment, right? So now we need to understand her genomics. In the blue box, wild type, nothing is found on circulating tumor DNA, a plus minus a biopsy of the liver metastasis and NGS. Next choice, an ESR1 mutation, which in her case is exactly what was found. And then lastly, she could have had a PIK3CA, AKT, PTEN mutation, either in isolation or co-mutant, for example, with an ESR1 mutation. So in this particular woman's case, she has an ESR1 mutation. We certainly want to utilize an oral SERD or once approved the Protac vepdegestrant. And we will have, once we have FDA approval, 3 options for monotherapy: elacestrant, imlunestrant, the oral SERD, or the vepdegestrant, the Protac. We will also have the combination of the imlunestrant plus abemaciclib based on the EMBER-3 data. This is a discussion with the patient. I think because she had bone and liver at presentation and because she had only 18 months of progression-free survival, I would lean towards the combination in her case with the imlunestrant to go after that ESR1 mutation and then switch her CDK4/6 inhibitor from ribociclib to abemaciclib. So that would be my choice in her particular case. But we do have the opportunity to talk about monotherapy with her as well.
Right. Fantastic. And thank you so much. In fact, that is exactly what I was hoping that we could talk about. That how do we make this decision? It's an embarrassment of the richest, isn't it? We're going to have more than one option that is applicable, which is a good problem to have, but also a tricky one sometimes, because then we have to figure out what's the right choice and is there a right choice and how do we come up with a decision for a right choice for a given patient. So broadly, if you were to think about monotherapy and combination, assuming both of them available to you, is there a particular recipe for you to then figure out that combination is the way to go for this particular patient versus monotherapy? How do you think about that? If you could talk to us about that.
Well, assuming she's got the ESR1 mutation and she had more than a year of benefit from the CDK4/6 inhibitor, she could be, if she had, for example, small volume bone only disease, relatively asymptomatic, you could consider an oral SERD monotherapy such as elacestrant, soon to come, the vepdegestrant, which of course is a oral Protac, or the imlunestrant. I think for patients with heavier tumor burden, particularly liver metastasis, and she got 18 months, for de novo metastatic, the median would be 2 years. She'd have a little bit less than that. I'd be leaning towards the combination therapy for her. So it would basically be based on overall tumor burden and biology of the disease, really defined by how long her prior treatment was, symptoms, overall tumor burden, and organ function, et cetera. But in this case, since we hope to have that combination of imlunestrant and abema in hand, in soon, that would be my option, my choice for her.
Fantastic. Thank you so much. That totally makes sense. So thanks for walking us through that logic in this particular case, at least. And, traditionally, when we think about no biomarkers, we always, reached out for everolimus in such conditions, right? We would think about, can we use a combination with everolimus when there is no biomarker? We also heard about EMBER-3 and how EMBER-3, the combination, potentially is active even regardless of an ESR1 or a PI3K mutation. So again, we might have more than one choice. How do you think about that? And how do you, put that into context if the ctDNA testing in this particular patient did not yield any biomarker? How would you think about those data and what would you choose?
Right. And, I have not been a big fan personally of everolimus post-progression on CDK4/6 inhibitor for patients with liver metastasis. Bone, great. I have not had good success with liver metastasis, so that wouldn't be something I would lean towards. Single-agent fulvestrant is really quite ineffective post-progression on CDK4/6 inhibitor therapy. We did see data from the post-MONARCH trial combining fulvestrant with abemaciclib. That could be an option for this patient. But an all-oral combination of imlunestrant and abemaciclib would probably be my choice, again, just for the convenience. In ESR1 wild-type patients, the oral SERDs are identical in effectiveness to fulvestrant. It's not that they don't work. They're just identical. And so the imlunestrant and the fulvestrant, they're the same in the EMBER-3. It's the same efficacy. So the combination of the imlunestrant plus the abemaciclib in EMBER-3 in the ESR1 wild-type population was substantially more effective than single-agent imlunestrant, not surprisingly. So that's what's nice about that combination. It'll be available to us both for ESR1 mutant as well as ESR1 wild-type population, giving us an all-oral option for patients.
Yeah, fantastic. Again, thank you again for walking us through. I think it's so true that, while everolimus is an option, if you look at the most recent single-arm FRIEND study, that provided some data for fulvestrant with everolimus post CDK, again, 57 patients, very small study. It was still 6.8 months. And I think with EMBER-3, which is a larger phase 3 trial, a randomized trial, we did see that post CDK, the combination of imlunestrant plus abemaciclib was 9.1 months. And so it does seem like this all oral option is one advantage, of course, to have for our patients. And it seems like the PFS benefit that we've seen, again, we can't do cross-trial comparisons for efficacy, but at least when we think about data that we have, 9 months seems to be more appealing for a patient population. So do agree with your thought process there. What about if the tumor also had a concurrent PI3K mutation or did not have ESR1 and had only a PI3K mutation? How do you think about that particular scenario?
So if they only had a PI3 kinase mutation, again, we will have options. We could certainly consider the fulvestrant capivasertib combination, which has been heretofore my go-to. Again, I'm intrigued in the EMBER-3 trial, specifically looking at patients with the PIK3CA, AKT, PTEN mutations. The combination of the imlunestrant and abemaciclib, again, was significantly superior to imlunestrant alone. And again, in a ESR1 wild type, we would think of the effectiveness of imlunestrant very similarly to fulvestrant alone. So that combination of going after that estrogen receptor, regardless of ESR1 mutation status, plus abemaciclib was effective regardless of the molecular subtype that we know to look for and regardless of prior CDK4/6 inhibitor therapy. So that would be very appealing to me. So I would be between fulvestrant and capivasertib or imlunestrant and abemaciclib. If the patient was co-mutant with ESR1 and a PIK3CA, AKT, or PTEN, there we would really need to go with the imlunestrant and abemaciclib because that's the only combination data we have that will be available to us once FDA approved to go after the mutant ESR1 with imlunestrant, and then the abemaciclib is effective regardless of wild type or alterations in the PI3 kinase pathway.
Thank you. I think that very, very helpful to understand this perspective and this logic behind how you would approach that scenario. And does the use of a specific CDK4/6 inhibitor in the first line setting matter when you think about these data sets that are available in the second line?
No, in the EMBER-3 trial, patients, 60% had a prior CDK4/6 inhibitor. And that's where we actually saw a very nice improvement. It was 9.4 months. Is that right? It was 9.4 months? No, it was 9.1 months in the prior CDK4/6 inhibitor patients with the combination. And they had the prior palbociclib or ribociclib and then came in with the imlunestrant and abemaciclib afterwards. So we have very good data on that. And then also in the post-Monarch trial, 100% of the patients had prior CDK4/6 inhibitor. And then the combination of fulvestrant and abemaciclib was superior to fulvestrant alone. So, I think that most patients will be getting more often than not ribociclib in the first line setting, although there's certainly room to use any of the CDK4/6 inhibitors first line. But if they did get palbo or ribo first line, there's very good evidence now for utilizing the abemaciclib in the second line setting.
Thank you. Yeah, no, I agree with that. I feel equally convinced that I think regardless of palbociclib or ribociclib, which is predominantly what patients would be getting, some patients could be getting abemaciclib. That's a different scenario, but that's a fewer group of patients, I feel like, at least from what we've understood, and certainly good data across data sets for abemaciclib in the second line. So I think this was a great discussion. Now let's move on with the second case. We now have a 62-year-old postmenopausal woman with ER-positive, HER2-negative metastatic breast cancer. She had received prior adjuvant endocrine therapy, but developed recurrence within 12 months of completion of adjuvant and AI therapy, and currently has extensive visceral metastases. ctDNA testing revealed neither the ESR1 nor the PIK3CA AKT PTEN alterations, and no germline BRCA1 or 2 mutations were detected as well. So maybe, Joyce, you can walk us through the treatment algorithm for such a scenario.
Absolutely. So she has had her AI and she's recurred within a year of stopping it. And she recurred very aggressively with diffuse visceral metastasis. She really has endocrine therapy resistant disease. So I would not be interested in single agent therapy for her. And we do want to evaluate her at that point for PI3 kinase mutation, because down the bottom of our slide there where it says PIK3CA mutation, she's recurring within a year of stopping her adjuvant endocrine therapy, she's a candidate for fulvestrant and inavolisib and palbociclib. Very, very important to know that. Now, in this particular case, she does not have any alterations, and so she needs a CDK4/6 inhibitor. She's not had one. So we actually have two best choices for her, in my opinion, up at the top there, the fulvestrant CDK4/6 inhibitor or the imlunestrant plus abemaciclib. I'm very comfortable with both of those options. You can see the other option in blue there, imlunestrant, but that is for an ESR1 mutant cancer, or elacestrant could be another option for an ESR1 mutant cancer. But I think that's where we are right now in the first line treatment for this patient. She's been appropriately looked at molecularly and without any alteration. I think we've got to give her a CDK4/6, no question. And she needs a ER targeted agent, either fulvestrant or the imlunestrant.
Fantastic. So maybe let's think about this case a little bit more and think about scenarios that we might face, right? So which disease, tumor, treatment, and patient factors or characteristics would we consider in the clinical decision making among these patients? I think you walked us through some of this, that, it's a recurrence within 12 months of endocrine therapy. And if it was ESR1 mutation, you could consider monotherapy. But if you, as you pointed out, if you have the ESR1 mutation and the patient has not had a CDK, is there a preference in the first line you would have in such a scenario?
Yes, she really does have to have a CDK4/6 inhibitor. And even with an ESR1 mutation, elacestrant was evaluated after a CDK4/6 inhibitor. So she really needs that. If she's wild type on ER, as this patient is, then either fulvestrant and a CDK4/6 inhibitor. I will tell you that for an aggressive visceral recurrence, my preference would be abemaciclib for the patient. If she's got an ESR1 mutation, then imlunestrant is the choice. It's our only established combination therapy, is the imlunestrant plus the abemaciclib. Now, it turned out in EMBER-3 that regardless of mutation status, patients benefited, significantly more from the combination of adding abemaciclib to imlunestrant compared to imlunestrant. So if she had a strong preference for an all-oral regimen in the absence of an ESR1 mutation, then she's also a candidate for the imlunestrant plus abemaciclib. So, but those are the kind of the two choices I would come down to.
Yeah, that makes sense. As you pointed out, EMBER-3 allowed both first-line and second-line patient population as long as they had recurrence on or within 12 months of either their adjuvant endocrine therapy or progression, on their first-line metastatic AI-based therapy. So this patient could be a very appropriate candidate for that therapy or a fulvestrant CDK, as we have been treating before these data. And I think we touched upon with the ESR1 mutation, how we would think about this. What if there was a PIK3CA AKT-PTEN alteration present? How would you approach this case from that perspective?
So if she has a PIK3CA mutation and she then fits the INAVO 120 eligibility criteria, so if her hemoglobin A1C is less than 6%, I think the best treatment for her would be inavolisib, fulvestrant, and palbociclib, as in the INAVO 120. If she had an AKT-PTEN mutation, however, she still needs a CDK4/6 inhibitor. I would not prioritize capivasertib, for example. So she's never had a CDK4/6 inhibitor. She needs one. And so it's really, again, if she needs one, my preference would be abemaciclib because she's got very aggressive disease, and it's either going to be with fulvestrant or imlunestrant. Imlunestrant, either ESR1 mutant or wild type, fulvestrant only ESR1 wild type. And so all oral regimen, I think, will end up being very desirable, be very appealing to women, I think.
And if you had both ESR1 and PIK3CA in this first line setting, do you think the INAVO 120 regimen would still be appropriate?
Probably not my ideal, to be honest with you. One could potentially argue that, and I don't know that we've seen the data yet, Kamal, from the INAVO 120 for those with the PIK3CA who also were co-altered with the ESR1. So that could be an option. But I'll tell you, if we've got those two targets right there that no doubt are very, very important in this rapid recurrence in this visceral disease, I would like to go after that mutant ESR1 with one of our oral SERDs. And then, of course, in combination, she's got to have a CDK4/6 inhibitor. So I probably would prefer the imlunestrant abemaciclib combination in the context of having the dual mutations, although I think one could make the argument for the INAVO120 regimen as well.
Yeah, no, I think absolutely appropriate. And thanks for walking us through. You're absolutely right. We still await data for other alterations from the INAVO120, specifically looking at what would be the scenario if there was an ESR1 mutation also present. And certainly the EMBER-3 did provide us with that data, but it's clearly a data-free zone. We really don't know what the right approach would be. I think it's very appropriate to think about the triplet first, and then maybe an imlunestrant abema-like regimen in the second line setting if it was still appropriate, or in a certain scenario, if you wanted to go with the doublet first and keep, capivasertib or something like that at the back end, if it was an AKT or a PTEN alteration, that would be appropriate as well. So I do think we need to await a little bit more from subgroup analyses from these larger data sets to be able to understand this better. Hopefully, when Capitello 292 reads out, which looked at, capivasertib plus CDK4/6, including ribo and palbo, and fulvestrant in this setting, maybe for AKT alterations, we could have that as an option. And hopefully one day we'll have a novel endocrine agent and a triplet as well. So our future is still going to depend on all those newer readouts that might come out eventually. Now, moving on to then improving adverse event management, talking about adherence and persistence with oral therapies. What do we know about patient burden and preferences related to oral versus other routes of delivery for breast cancer therapies in ER-positive, HER2-negative metastatic breast cancer? And maybe you could talk to us a little bit about patient perspectives and preferences, Joyce.
Absolutely. I think patients are generally open to whatever the most effective therapy is for their breast cancer, and particularly their metastatic breast cancer. But of course, there's actually a lot of evidence that oncology patients prefer oral regimens to a systemically administered IM or IV therapy. I think more than anything else, it's convenience. It's the ability to receive care at home and keep less time in the office and more time dedicated to their other obligations in life. Of course, IM or IV injections can be uncomfortable, and they just have a greater sense of control. And, I think we all understand this very well, that this is a big deal. Driving into the cancer center on a regular basis is very, very difficult. It's very inconvenient. It's very time consuming. It's a real hardship for a lot of patients. I think that's more than anything. And just the idea of staying away from the cancer center and having that less anxiety and that more sense of health because you're staying away from the cancer center. So I think oral therapies are very, very definitely preferred, if they're equally effective or even more effective.
And how do these oral SERDs compare in terms of the adverse event profiles? And are there considerations for management of the specific adverse events when using these therapies, either alone or in combinations? And really, what guidance would you offer based on your experiences to maximize adherence and persistence to these oral therapies, which really is very, very important, especially as we start utilizing these agents in the first-line metastatic setting for a long period of time, and more importantly, the early adjuvant setting where they're being interrogated currently in phase 3 trials.
Well, the great news is they're extremely well tolerated. So this is fabulous. We're familiar with elacestrant there on the top left, and you can see that the red is pointing up there towards nausea, which is really the main toxicity. Really, I think of it as the only toxicity of elacestrant. It goes away over time and really can be mitigated by taking the medication with food. Camizestrant over on the right, another one of our oral SERDs at higher doses, you can see some photopsia and you can see some bradycardia, but at lower doses, it's very, very little, of that. Imlunestrant in the bottom center there's some fatigue, there's some nausea, and there's a little bit of diarrhea. Again, nausea. These are very transient and again can be mitigated with taking it with food. Fatigue as well, usually tachyphylaxis and goes away, and diarrhea is really quite minimal. Again, these GI issues tend to go away pretty rapidly. And giredestrant at higher doses, you might see some bradycardia, but at the lower doses, really not. And amcinestrant is no longer in development. So these are overall very, very well tolerated. One of the key things we want to do with our patients, of course, is really help them adhere and persist with therapy. Now, in the metastatic setting, that's really less of an issue as long as patients can get access to the medication. Then we have a whole, group of patients in our cancer centers, a group of people in our cancer centers that are helping patients with access and with co-payments, et cetera. But most patients understand the necessity, fully understand it. We're being very proactive, helping them with adverse events. And we are really managing comorbidities as well and helping them access other specialists and their primary doctors in the healthcare system so that they can get the help they need. And again, trying to help them with the issues around convenience and travel and cost. And so what can we do in particular? We can try to keep the regimens as simple as we can. Very, very good education, the motivation, what's the upside of taking this, also what to watch out for toxicity wise, when to call us. And basically it's education. I also find that seeing the patient fairly regularly when we first start a new therapy is very, very helpful. They really know that you're in there with them on it. You're really managing toxicities. And then we can start stretching out the visits once we know women are doing very well with the therapies.
Absolutely. I think our nurses, our frontline, teams that really interact with them, having them reach out to them or making them accessible, making ourselves accessible in those earlier time points when they just begin a new therapy is so critical and so key, just so that we can actually help them or maximize the support they need with any side effects, understand what they want to communicate, make any dose modifications if we had to, when we can, and when appropriate, so that they can stay on this therapy and derive the benefits. So thank you for providing these pointers. Now, from a patient perspective, I'd love for our audience to watch this video from one of our patients, really highlighting the importance of considering patient needs and preferences, including route of delivery of therapies, choices of oral versus intramuscular intravenous therapies, and engaging in this shared decision-making process with their physicians. Among these patients, we want to see that with their care partners, and how does this play into their decision-making about what therapy they would like to start. So please see this video.
Choice is a wonderful thing to have, and we have that now with endocrine therapy. We have oral medications and we have injectable medications, and who knows, maybe in the future we'll have a transdermal patch. With the way that things are moving forward, who knows what we'll have. And I think it's really important for you as the clinician to talk to your patients about what is important to them and to ask them that question periodically, because it can change as their life changes and as they live longer with metastatic breast cancer. Some people may rather go see a doctor every month, may want to get an injection, may not want the side effects that can come with oral medications, where other people may live far away from your clinic and have to drive over an hour or 2 or 3 hours, and an oral medication that can be delivered to their home may be more convenient for them. And things may change. Someone may be happy on one medication for a long time, but circumstances change. So I think it's important as new drugs come available that you continue to let your patients know about what is available, about what the data shows, especially when there is progression. So they have the information that they need to make the decision that is best for them. Also, there's all these medications that are currently available now as monotherapy. Your patient may have been on a combination therapy before. There are trials with combination therapies. And I think, again, you have to keep yourself informed and keep your patients informed. And also, patients need to do a little bit of the work as well and keep informed about what their treatment options may be now and in the future.
So thank you so much, Joyce, for this lovely discussion. It was really, really fascinating to hear your insights, your suggestions, your thought process, your logic about all these therapies that we currently have. There's so much happened. There's so much happening and so much more that is currently in the pike or in late phase that we will hear data from, which might further impact our treatment algorithms that you very nicely summarized for us today. Any final comments or thought processes you would like to share with our audience today?
I think it's really been fun, Kamal, to think through these new options coming our way. And I would just emphasize the importance of the ctDNA evaluation, the serial testing for CT DNA to look for ESR1 mutations and mutations in the PI3 kinase AKT P10 pathway, because we do have a number of options. And I would just say it's great to be now moving towards targeted therapies in combination with the imlunestrant and the abemaciclib. That's our first oral SERD in combination, which we really look forward to being able to bring to patients, because we do want that longer progression-free survival we see with the combination therapy in general.
Thank you so much. And thank you all for joining in today for this very interesting workshop.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, METAvivor. This activity is supported by an educational grant from Lilly. To access all materials for this activity, visit peerview.com/XYR860.